Neuropathy, like many chronic pain conditions, has a variety of causes and a variety of often less than satisfactory treatments. Neuropathic pain, next time on Call with the Prairie Doc. Hello, I'm Dr. Deb Johnston, tonight's Prairie Doc. We are excited to be able to continue to provide our viewers with trusted health information during our 21st season. Thank you for joining us this evening. Tonight we will be discussing advances in surgery. Joining us in the South Dakota Public Broadcasting Studio in Rapid City are Dr. David Fromm and Dr. Jay White, both from Monument Health in Rapid City. Welcome, gentlemen. Thanks so much for spending your evening here with us and sharing your expertise with everybody here in South Dakota. Dr. White, Jay, tell us a little bit about your background.
I'm an ear, nose, and throat specialist. I've been here in Rapid City for now 12 years. Originally grew up in a small farming community, East River, South Dakota, in the Aberdeen, Watertown, Huron area, Dolan, South Dakota. Undergrad at USD and med school in Iowa, and all my training was in Detroit.
And what drew you to ENT?
I'd have to say the types of surgeries, the delicate surgeries in small cavities, small openings, and I think a big draw for me was we do a fairly large number of pediatric care and surgeries, so peds was a big draw for that.
You like children?
Yeah, I love children. Big part of what we do.
Yes, tubes and adenoids, tonsils.
Yeah, all kinds of head and neck disorders. Children.
Cleft lip and palate.
Exactly.
Yeah, exactly. Dr. Fromm, tell us a little bit about your background.
Sure. I was born here in Rapid City and circled back. I went to college at St. Olaf College, which is a small school just south of the Twin Cities, Minnesota. Came back to South Dakota for medical school, went to the University of Iowa for 5 years for surgery training, and was recruited to come back out here for practice. So I've been out here since 2007. And so, attending and a partner with the Monument Health Department of Surgery. I also have a role with the University of South Dakota for teaching, especially for this campus as well. I specialize with the general surgery, which is a broad field, but my focus with the general surgery is bariatric and metabolic surgery. Foregut, which is esophagus and stomach. We still do quite a bit of everything as well. We still cover trauma, still do some pediatrics, we still cover colorectal, breast, all the things they were asked to do.
Okay, and what drew you to surgery?
I come from a family of physicians, and I think it was one of the things that growing up, it was so fascinating and interesting, but I think when we became older, you wanted to do something different. But you start to kind of realize as you get a little older what you're good at and what you're not. And then I figured out that this is what I was good at, and this is where my passion lies. As a medical student, you're exposed to so many different things, and you get so many different pieces of advice and things. And in surgery, I like the field of surgery because there's the history behind it. There's the art behind it. I like the idea of the investigation behind some of the problems you see with the surgery. Seeing it from the start to whether it's surgery or not surgery, but the field that you cover, and then seeing the final results with that. And I found that fascinating.
And what made you decide that bariatrics was a niche that you wanted to fill?
I trained at the University of Iowa, and if you know the history of bariatric surgery, Dr. Mason was credited as being one of the forefathers, so to speak, of the bariatric surgery. So we were exposed to that a lot during my training. When I came out here to Rapid City, it was really in the practice that I started with that was the need. I've always loved minimally invasive surgery. They used to joke for the medical students that out here that would go to Sioux Falls, they'd say, "Oh, Dr. Fromm out there could tie his shoes with a laparoscope if you would," joking. And but within the field of laparoscopic surgery, you're always looking for things that are challenging. Of course, you can do gallbladders, you can do appendectomies. To do a gastric bypass was more of a challenge. So I kind of went a little bit with that. But then we start to get more involved in your practice. You really start to look at outcomes. It's great to see people back in the clinic and they say, my hemoglobin A1C, which is a measure of diabetic control, is normal. I'm no longer diabetic. I no longer have high blood pressure. My cholesterol is normal. My doctor says I've never looked this good ever. I never felt this good. So it's really addictive to have people come back and to really see those results. Or sometimes, for some of the other things we do, we really do, work hard for our patients. Say in the field of oncology, we're doing things for, removing tumors and things like that. And sometimes when you say the quality of life is not always better afterwards, but that's what it requires for that particular case.
I can see where that would be a really addictive feeling. Yeah. Is there a surgery that you do in your field that you feel really makes that huge difference in somebody's life?
I think with ENT, what I tend to migrate to is the field of rhinology, nasal surgery, sinus surgery, and a lot of the patients who come in with head and neck type of disorders, it's been told that if you have a sore arm or a leg or a body part, there's a way that you can kind of put that pain or suffering away. But when the pain is or suffering is part of the head and neck region, you really truly can't escape it. So a lot of our patients who come in with those types of head and neck pain and pressure issues and sinus surgery has been a real reward, because the differences you can make in their quality of life and in relief of that, and sometimes in a very large way and sometimes in a small way. The rewards are great in that area, and that's kind of where I put my focus to. Allergy, rhinology, sinus surgery, and then the other thing I do quite a bit of is pediatrics. It's mostly the bread and butter pediatrics, tonsils, tubes, things like that.
We had talked a little earlier about sleep apnea and sleep apnea surgery that you do, and I can imagine that would make a huge difference in somebody's quality of life as well. Can you tell us a little bit about that?
Yeah, actually there are some newer treatments for obstructive sleep apnea, and in the history of head and neck surgery for sleep apnea, there are certain parts of the anatomy that really can be changed or altered.
Let's back up just a minute, and some of our viewers may not be familiar with what causes obstructive sleep apnea.
Great question. Many risk factors are involved with obstructive sleep apnea, but overweight and obesity are probably the biggest risk factors that we see. Male, age, and a lot of the anatomy that we deal with in the head and neck region has a big role to play in obstructive sleep apnea. Understand that the obstruction in obstructive sleep apnea occurs somewhere between the lips and the nose and the vocal cords. So in what we call the upper airway, which is a very complex area, there is often multiple areas where either partial or full obstructions occur. Some of the obstructions are bony, many of which in the lower throat region are more of a soft tissue area. And it's the soft tissue areas in the obstruction that are the more challenging areas to treat, because there's circumferential collapse, there's collapse of the base of the tongue, there's the tonsils, there's a soft palate, and many areas within the nose. So it's a very complex condition that has multi-levels and multi-factors that go into why people eventually have an obstruction or a partial obstruction. And the real challenge that we've seen in ENT in treating those areas has always been the tongue base or the base of the tongue. So when you lie back in a supine or recumbent position, the tongue will sometimes, in certain individuals, fall back and cause or be the level of obstruction. And it's always been a challenge for us to treat surgically. I mean, how do you treat the tongue? It's a large muscle housed in your mandible. So if the mandible is small, treating the tongue base has always been a challenge. Well, newer procedures have been developed in the last 4 to 5 years, and you may have seen it advertised as the hypoglossal nerve stimulator. The hypoglossal nerve is the one that innervates the tongue and the muscle, and there's a stimulator that is placed on the nerve around your submandibular gland. A device is implanted here, and there's another electrode that attaches to the intercostal muscles. So when your body senses you want to take a breath in, the intercostal muscles are stimulated, which then stimulates the base of the tongue, in theory, pushing the tongue forward and clearing the way for that obstruction. So hypoglossal nerve stimulation is really kind of the latest attempt to treat probably one of the most challenging parts of obstructive sleep apnea that we're faced with in ENT.
And how do you know where the obstruction is in an individual. How do you determine what might be an appropriate surgical approach, if there even is a surgical approach for
Great
this
question.
person?
And fundamentally, that's part of what goes into treating patients with the hypoglossal nerve stimulator, is that you have to induce sleep, or what can be perceived as the closest thing to sleep in a person, and then monitor their airway. So we use drug-induced sleep endoscopy, where the patient is given medication to induce a situation close to sleep, and an endoscope is placed into the nasal cavity, and you literally watch the dynamic movement of the upper airway and try to identify where collapses are occurring or partial obstructions are occurring. If it's determined during sleep endoscopy that a major force of the collapse is based on the base of the tongue, and there's a lot of other factors that are involved in the workup, but it's a very stringent workup to determine, is this hypoglossal nerve stimulator going to be the best treatment for this type of patient. Again, given multiple areas, multiple levels of obstruction, the sleep endoscopy tries to really zero in on that and ferret out patients who aren't going to be candidates for the procedure, and really focus on the ones that could be benefited by this.
So that's a very new technique too.
Yes.
Yeah, just figuring out who might qualify
Correct.
for this. Can you think of an extension to your own field, Dave? Something that's the evaluation of the patient has changed in the course of the time that you've been practicing medicine?
In terms of obstructive sleep apnea?
Well, no, anything that you do.
I think a lot of, especially within the field of bariatric metabolic medicine, it's more of the understanding of kind of like what you're describing, what is the etiology that drives us, what is the cause of this. And it's multifactorial, but with our program for Monument Health, we've built a multidisciplinary practice. And what that means is that it's not just surgery, it's medicine, it's psychiatry, and really sort of identifying, what are the factors that have led to, at least your difficulty of weight with an individual, and how can you then take that understanding and then create keys in which to drive the effects that your patients want. A lot of it is, obstructive sleep apnea. I mean, it's so common with patients that we see, for instance, that a lot of times we end up doing sleep studies for our patients because it's almost universal. Recommending CPAP is so beneficial for our patients. If they listen about this, I think a lot of my patients would be really excited if they could come off every sleep
Get rid of their sleep apnea, which is the goal of many, many patients who suffer.
To get rid of it. A lot of patients in my practice just can't tolerate it. They really struggle with that. So something like this could be a great service for them. And I'm sure in your patients you see both directions. People that develop sleep apnea, they're overweight, but then they eat, they change their behaviors to try to compensate for the symptoms of the sleep apnea too. So I'm sure it's a vicious circle for a lot of your patients. So I always think about diagnosing appendicitis. When I went to medical school, I remember the saying was, if you don't take out at least 10% of healthy appendixes, you're not taking out enough appendixes. You're missing those cases of appendicitis. And I don't think that surgeons feel that way anymore. Is that still something you guys say?
The role of medical management of acute appendicitis has become part of the practice. The idea that everybody with appendicitis does not necessarily need surgery. It's hard. If it was me personally, I think I'd still probably sign up and have my appendix out. But I always tell my patients I'm strongly biased when I recommend anything, and I'll let them decide. But I think nowadays, this is evolution in terms of radiology, in terms of everything else. I mean, it's rare that you would ever, take out a healthy appendix. I mean, most of the time, you're pretty much certain of the diagnosis before you're committed.
I think that's the big change, is the ability to be certain, reasonably certain, based on that CT scan, and whether this is an appendix that needed to come out now or not. That's a big change in the field as well. In the early 2000s, Dr. Maria Bell was one of the first people in the country to use the Da Vinci robotic platform for gynecologic surgery in Sioux Falls. Today, the Da Vinci robot is used for various surgeries and can be found in many hospitals across the country. One of the newest Da Vinci robotic platform models is used in Brookings, South Dakota. Prairie Doc reporter Sam Schauer visited with a surgeon to find out more.
The Da Vinci Xi is one of the newest models of the Da Vinci robotic platforms for surgery, and Dr. Teresa Wee Trudeau is one of the specialists licensed to operate it in Brookings.
The Da Vinci Xi is a robot that is used for laparoscopic surgery. It can also be used sometimes in cardiac surgery, but here in Brookings we use it just for laparoscopic in the abdomen. It can be used by multiple different specialties: general surgery, OBGYN, and urology. It allows us to do surgeries more minimally invasive, which is better for the patient.
And with someone controlling all four arms, precise cuts and incisions can be done without fear of slight movement.
Now there are 4 different arms on this robot, and we're able to move one of the arms into position, and then it will stay there once we grab control of another arm.
Dr. Wee Trudeau says this robot benefits patients with less pain and less hospital time after surgery.
On the arms of the robot where the trocars go in, they have a center point, and the arm will move around that center point, and so there's not near as much torquing on the abdomen, which decreases their pain. Because people have decreased pain, there's decreased hospitalizations, the length of stay for each of the procedures, and so people are able to go home sooner. Also, with smaller incisions, there's a decreased risk for infection, including wound infection. There's less exposure of the abdominal contents to the air as well.
Other advancements that seem futuristic could be closer than we think.
Now there's talks of artificial intelligence. Can we make something that is able to tell us, like, are these cells cancerous or are they not, in real time? It's not fully developed yet, of course, but those are things that are on the horizon, and so there'll just be more and more advances as time goes on.
But for the present, the Da Vinci Xi is the trailblazer for surgery.
So it's been a long time that the Da Vinci robot's been around, and it's only been in the last probably 8 to 10 years that it's really taken off in general surgery.
So, one thing to talk about, I realized we didn't really define bariatrics, and I'm sure a lot of our viewers are probably familiar with bariatrics, but what is bariatric medicine?
So bariatric medicine, you can define as weight loss surgery, but I think that people would like to broaden that. I broaden the definition for that for metabolic, which would mean diabetes, high blood pressure, high cholesterol, all the things that you typically think could lead to potential heart attack, stroke, kidney disease. The idea behind it is that you're providing preventative medicine and preventative surgery for those patients. But it's bariatric metabolic surgery or weight loss.
The short answer is weight loss. The long answer is a lot more complicated, as is true for a lot of things in medicine and surgery. So the robotic surgery, I don't think there's much of a role for robots in ENT, at least in the average ENT's practice.
A small role in oral cancer and throat surgery. But yeah, most of it is general.
The general surgeon, the orthopedics. Can you tell us a little bit about the history of the robot? How was that developed?
Well, we were discussing earlier that there's probably a military application that's probably originated with the idea that a battlefield somewhere, you may not have a surgeon that's able to provide that procedure that may be necessary. But on a military base, maybe halfway around the world, you would. And so you have somebody that can jump onto a computerized console. You can have somebody that's there on the field providing the actual instrumentation, and somebody else is doing the surgery remotely. That was the original idea in robotic surgery. But they took that application and looked at the advantages of that and applied it to our standard ORs. And so what you see now is a platform that has tremendous precision, allows the surgeon to do things that would be quite difficult to do through a minimally invasive approach. It's interesting that within the field of surgery, still rely upon a needle and thread. My kids will sometimes ask, well, can you sew? And I'm like, well, yes, we can sew. If we need home projects, we'll sew. But within the field of general surgery and in surgery and urology and gynecology, we still use needle and thread, and it can be quite difficult to mimic the human hand in a very confined space, minimally invasive. So the idea with the robot is that you have instrumentation, you have a tremendous amount of control over it. You also have the tips of the instrumentation that articulate, almost like the human hand. So it allows you to do very complex maneuvers that otherwise wouldn't be possible.
And in the application in head and neck, most of the deep spaces within the throat where cancers occur, it used to be where, in some cases today, where you'd have to split the mandible, pull it aside to gain access to get surgeons' hands into that confined space. And with the transoral robotic surgery, the robot can do such a better job of resecting those deep tumors without the hideous disfiguration that occurs with just getting access to those areas. So we see that in head and neck oncology as well.
I would imagine just the pain after surgery would be much better too if you don't have to split the jaw, and would make a big difference for the patient experience.
Recovery is shortened. Their time that it takes to get back to a more normal lifestyle is greatly reduced. And hospital stays are in general reduced as well.
I would imagine that also comes with improvement in disease-free survival. You get a better...
You get better resection, better clearance of tumor from margins by getting into those tight spaces. Absolutely. And it takes a team, much like Dr. Fromm was saying with his bariatric surgery. It's just more than the surgery. It's the whole team of people that you surround yourself with that make those moments happen for those patients who come back in and find the rewards that you're able to give them. Absolutely.
Yeah, your teams, and I think that may be one of the big changes we've seen in medicine is moving to more of a team-based approach. And the surgeon is part of the team, but the oncologist is part of the team, the psychiatrist is part of the team. There's a lot of people coming together to try to figure out what the best thing to do for that patient is and how to best support that patient through that whole process. Thinking about the changes, the evolution, I think a lot of our viewers, when they think about surgeries like gallbladders and appendectomies and those kinds of things, think about the scars. The big old scar and that just beneath the right side of their rib cage, or the littler scar just above that right hip. Tell me how just routine, everyday surgery has changed in the course of your lifetime.
Well, if you think back about gallbladder surgery, you would see people that had surgery and they'd have the scar that come across. And patients have that surgery, it's successful, but they're not going to go home. The recovery once they leave the hospital is going to be prolonged. Nowadays it's routine to do laparoscopic, even robotic gallbladder surgery. They're very small incisions. The discomfort is fairly minimal. The recovery is fairly quick. I would tell patients I see in the office that if you have an office job, you may get back to work within 4 to 5 days. If you work construction, maybe a little longer, but they heard of open surgery that just wasn't possible.
How long? I think it was probably a little bit before your time that the open procedure was common, but what is your understanding of how long somebody would have to stay in the hospital after they have their gallbladder out, for example?
I would say probably 3 to 4 days. Just the incision is large enough to be uncomfortable that they have to use quite a bit of pain medication, and it may be that the intestines are a little bit delayed in terms of function for a period of time. So hospital stay would be much longer.
And of course, the pain medicine they need wouldn't do their gut any good either in terms of waking up. That's a difficult thing too. So. Let's talk a little bit about sinus surgery, because that's certainly something that is an everyday occurrence for a lot of people, certainly an everyday occurrence for you as the person performing the surgery. How would you say that's changed in the course of your career?
I think the evolution of sinus surgery has maybe evolved out of just surgery as the single modality for treatment. And one of the things I think that drew me to ear, nose, and throat was that there's a lot of chronicity in our specialty, so we get to see patients time and time again to manage chronic conditions. And the evolution of the thought behind chronic sinus disease is more than just having the surgery that takes care of the problem, where surgery is now really thought of as a very powerful tool but the day-to-day management of those chronic disorders takes a much more substantial role in the long-term success in those patients. I think previously endoscopic sinus surgeons would do the surgery, and there wasn't enough knowledge base to understand that the daily care and the return to see their physician and their surgeon and follow-up, and kind of customizing each treatment plan for each patient, which requires different approaches for each patient. So I find that evolution has really made substantial changes in how I approach my patients and the outcomes that we've got from the prior surgeries with the day-to-day and month-to-month and year-to-year management. So I tend to see a lot more surgeons managing that chronic disease as opposed to just the technician stepping in, doing the surgery, and then returning them back to their primary doctor.
And that may explain why we're seeing fewer repeat sinus surgeries.
Exactly, and that's been a trend that I've observed in my practice as well.
Yeah, it used to seem like my patients would, well, it's been 2 years since I had my sinus surgery. I got to go have it done again now. It's time, I can tell. So.
Hopefully those days are long gone.
I sure hope so. My patients sure hope so too. Can you think of something else that's changed a lot in the course of your career?
I think that just everything is going towards less and less invasive. You talk about open surgery, even within laparoscopic surgery. Now there are things that are being done endoscopically. Some of the things that we're currently doing, within the field of bariatric surgery, we're doing revisions for patients who've had a history of a gastric bypass. It's been studied in terms of the diameter of the opening of the stomach pouch into the small intestine. It's called the gastrojejunoscopy. If that becomes larger in diameter, patients will now start to feel hungry, or they'll have that loss of satiety, loss of fullness, which can be associated with weight regain. To revise that would be either open surgery or laparoscopic surgery. We're now doing revisions that are done just through the gastroscope as an outpatient procedure.
Can you explain that a little bit more? And you mentioned endoscopy versus laparoscopy.
So endoscopy would be for audience, for people who are familiar with the colonoscopy. It's going through an orifice either through the mouth into the esophagus and the stomach, or from the bottom. If we're talking about the example that I use, it'd be putting a scope that goes through the mouth, into the esophagus, into the gastric pouch. And if you're familiar with the room-wide gastric bypass, the stomach pouch is fairly small, and then it's connected to the small intestine. And the idea behind the operation is really what I tell patients: it should provide decreased hunger and a better sense of fullness. And once that is lost, then you'll start to see weight regain. So for patients that come back, they would say, well, I have a history of a gastric bypass, and now I'm really hungry during the day, or when I eat, I don't feel like there's any stop like there used to be. When you look in the gastroscope, you can see the diameter, so the opening between the two, and if it's larger than, say, 2 centimeters, it's been associated with weight regain. You come in with a specialized gastroscope that has a stitching device that's on the tip of that, and you can actually stitch endoscopically to snug up the diameter of that. Patients come back and said, I'm not hungry. I now feel full, relatively full. That's been a big push. And you're starting to see other things that are now done even more through the endoscope. Transoral gastric fundoplications for reflux.
Now define that. What is that procedure?
So when you're talking to somebody that has heartburn, I always tell patients you can take medications, but it gets rid of the sensation of acid reflux, but you still reflux. It's a mechanical issue of the stomach and the esophagus. And what you are now able to do is you're able to rebuild the valve effect of the top part of the stomach. Surgeons have been able to do it open, they've been able to do it laparoscopically, robotically. They do things such as Nissen gastric fundoplications, where you're taking the top part of the stomach and then you're wrapping it around. Now we're able to do that endoscopically, where we're looking through a gastroscope and looking at the valve effect internally and rebuilding that valve effect internally. No stitches on the outside, no incisions on the outside. That's a big push in the evolution of surgery. Now you're starting to see medical doctors such as gastrologists getting involved with things where typically that would have been something that would have been strictly within the field of general surgery.
Fascinating. How great that more opportunities for that to be done for those patients that need that procedure. and I assume better recovery for those people without having holes in their abdominal wall musculature. A combination of neurology, neurosurgery, and radiology, interventional neurology focuses on problems related to the brain and spine. As one of the newest medical fields being introduced to hospitals, it's an unfamiliar term to many, but it can help with the diagnosis and treatment of familiar problems like strokes and aneurysms. Prairie Doc reporter Sam Schauer visited an interventional neurologist to find out more.
Dr. Jay Kim from Monument Health in Rapid City is an interventional neurologist specializing in health problems related to the brain, from spotting the injury to conducting surgery.
I work with other specialists such as neurologists, stroke doctors, neurosurgery doctors, intensive care doctors, and I would work with them to diagnose the disease, and then if treatment is necessary, such as a stroke treatment or aneurysm treatment, then I would go in with a special machine that we have at Monument Health to do the procedure.
Strokes are the most common diseases interventional neurologists will see.
If someone comes in with a bleeding or a stroke, that is ischemic stroke or clot stroke, we're trying to figure out why did they have that happen, such as, is there a blocked blood vessel? Is there aneurysm in the brain? Is there a malformed brain blood vessel? And that would require an interventional neurologist.
Interventional neurology began in the 1980s, but limitations of technology impacted the medical field of studies' impact.
In terms of stroke treatment, such as removing the clot, the FDA approval for this actually occurred in 2015. So you can imagine this is only 7 years ago that it got FDA approval, and it took that long to develop all these technologies.
Today's interventional neurology methods are much different than some of the extreme methods used as the field was discovered, particularly in dealing with aneurysms.
The traditional method was you would have to basically open up the skull and then go through the brain, or by going around the brain, that is, and then you would locate the blood vessel that bled, which is a blister aneurysm that bled into the brain area. And that would be the traditional method. You would go through around the brain and then basically locate the aneurysm, and then you would put a clip on the aneurysm, which is kind of similar to a cloth pin, if you can imagine, and then you would pinch off the blister.
Thankfully, advances in interventional neurology surgery have made safer strides thanks to minimally invasive small incision techniques.
At this point, majority of the aneurysm treatments are done in a minimally invasive fashion, and majority means greater than 80% in the nation, where we would go through the blood vessel in the body all the way up to the brain, and then instead of from the outside, we would go through the brain blood vessel into the blister pocket, and then we would basically seal that up.
What an incredibly fascinating and amazing and incredible technology. You guys have to be seeing changes in the outcomes for your patients and how people do when they've experienced a stroke or an aneurysm or something. Can you speak to that a little bit?
Well, having Dr. Kim here at Monument has just been a godsend for a lot of our stroke patients. We were limited in what we were able to do in saving the lives and the functionality of our patients. So it's just a big reward to see the outcomes that him and his team have created in our hospital, and we're just thankful to have him here.
And I think we're seeing that a lot in medicine, just these, from the standpoint looking out, it's this all of the sudden huge revolution. But if you step back and look and see the evolution and how these things were developed, there's a lot of work that went into developing that technology, and stroke is certainly a wonderful example of something that's been revolutionized by all that hard work on all those people's part. It's fantastic that the people of South Dakota have access to that kind of a service.
It is.
Really, really amazing. You had talked a little bit earlier about sinus surgery and the maintenance after sinus surgery. Can you talk briefly about what kinds of things a patient might need to do to maintain that?
Sure.
I know that that's a common problem for people.
Sure. Well, I think when you talk about sinus disease or any other chronic disease, whether diabetes, hypertension, what we do in medicine is we manage those diseases. And chronic diseases often are fraught with periods of time where you're feeling okay, and then there's a flare-up of some type. And how we manage those flare-ups in our chronic disease so that the flare-ups don't get out of control or the flare-ups don't occur with frequency. And in sinus disease, flare-ups and management they fundamentally are derived from one entity, and that's inflammation. When inflammatory elements enter into the equation, that's when sinus patients have problems. That's when they have flare-ups. So in the evolution of sinus disease management, anti-inflammatory stents have been developed where a steroid-eluting stent can be placed into the nasal cavity that releases steroid over time, reducing inflammation in those key areas where the pathway of drainage has to be kept open. And even pharmacologic advances for how we deliver anti-inflammatory or steroids within sinus rinses have been really on the forefront of what's been going on in the last few years. Sinus, go ahead.
And that would have a big advantage over the systemic steroids. People
Of course,
often
absolutely.
will come in and say, oh, my doctor back home used to give me a shot at the beginning of my allergy season, and wow, that worked great. And I'm sure it did for their sinuses, but it didn't do a lot of good for the rest of them. So.
And what I was talking about were the steroid rinses that have the same steroids that have been used in asthma patients for years. We're now putting into solutions. There are multiple pharmacies online that provide multiple different forms of therapies and solutions. And it is truly the day-to-day rinsing and caring of the sinuses that is really what gets the patients a better control of those flare-ups. When sinus disease is present, there's two things that occurs. There's that the mucus that you normally produce becomes greater in volume, as well as the ability of the sinuses to clear that thicker and more inspissated mucus becomes problematic. So to answer your question, it's the daily rinsing and caring, and in some patients, or many of my sinus patients, it's finding the right therapeutic rinsing options that work best at minimizing flare-ups, and when the flare-ups do occur, giving them some type of rescue medicine that they can reach for to reduce the intensity of flare-ups before it turns into an overall infection.
So telling my patients they need to get out their neti pot, you would echo that.
Yes.
That.
Please continue telling your
yes.
patients to do their daily care.
And I usually acknowledge that most people are not real fond of that
True.
neti pot,
That is true.
but it really makes a difference.
It does.
Yeah. Let's talk a little bit about the patient experience with surgery and with getting ready for surgery. David, one of the things that I've noticed as a parent is that it seems like the anesthesiologists are not quite as strict about that NPO thing, that nothing by mouth before your surgery. What have you noticed with that? And I know that is the anesthesia folks largely that are making that recommendation.
Well, there are still recommendations, that are through anesthesia that, if you've had a heavy meal, it's still going to be 8 hours. If it's been a lighter meal, maybe 6. If it's clear liquids, it may be 2. But we used to say universally NPO, which means nothing by mouth for X amount of time before your procedures. There are a lot of things now that are being brought forth what they call advanced recovery after surgery. We just call it ERAS for short. You see within the field of colorectal surgery, which means if you come in for colon cancer or diverticulitis, you're seeing it now within the field of bariatrics. You can probably see it universally in almost every surgical field. The idea would be that somebody that comes in for surgery, you would give them something that has glucose or something that has carbohydrates that's shown that is better to have a higher carbohydrate load going through surgery than strictly NPO for a period of time. Yeah.
So how about the tubes that people would sometimes wake up with after surgery, the tube that goes into their nose and sucks the air out of their stomach or the liquids out of their stomach with the idea that, well, this is going to help your gut wake up. Are you still doing that very often?
Not very much at all. In my training, which was 2002 to 2007, some of our faculty, we would panic if our patients' NG tubes, this nasogastric tube would fall out because we have to go back and put it in. And routinely, say after a colon resection for cancer, they'd have a nasogastric tube in place until they passed gas or had a bowel movement. And it really has been shown that, for the majority of patients, it's not necessary. It just delays, starting an oral diet, and it prolongs the hospital stay. Again, along the pathways of the ERAS or the advanced recovery after surgery, now it's been shown that if we allow people to eat or to have something earlier in the process, that's before we would say that they traditionally are passing gas or the other parameters that we'd use for starting a diet, that actually they do really well. Their gut function improves quicker. They're able to have, certain things in terms of less pain, certain other things, and they're able to leave the hospital at less of a time frame than they used to stay.
I think the take-home message is that as time goes by, it's important for us to keep evaluating what we thought we knew and test that and figure out, is that really the truth? We need to keep our minds open and recognize that things change, that our knowledge changes. So we've just got a few more minutes left, gentlemen. I'd like take-home messages, last thoughts. Jay, what would you like our viewers to take home from this show?
I think in general, I would encourage our viewers to really insist that their doctors take the time to answer a lot of the questions, especially about chronic diseases. Chronic diseases aren't a favorite among physicians and certainly among surgeons, but finding the physician who's going to take that extra time to really explain and educate. As a person whose training was in education before I made my way into medicine, that's been a big part of what I incorporate into my practice, and I find that patients really thirst for that. So just asking my colleagues to take that little extra time, it goes a long way, especially in the management of so many of the chronic diseases that we take care of.
And I think getting your information from a healthcare professional and not from Facebook is another good...
or Dr. Google.
Or Dr. Google, that's right. How about you, Dave?
So I would say, the idea of technology within the field of surgery, patients would come in and you would notice that they're not excited about being there. Nobody's excited about the prospects of having surgery, but with technology and technique, you now are allowing or providing safer procedures with a faster recovery. Where 10 years, 20 years ago, that wasn't the case. So I'd say for patients that are coming into our offices to be aware that, with the advancements in technology, the outcomes are better and the recovery is quicker.
And the getting ready for surgery is often less onerous too. So the testing that we need to do to make sure that this is the right test, the right surgery, so our confidence in whether this is going to be helpful to you or not is maybe a little bit better than it was before. So thank you very much, gentlemen. I really appreciate that you took time out of your schedule to educate our viewers about your respective fields. It's been wonderful having you on.
Thank you.
No, thank you.
And we'll be right back after this.
Miss an episode or looking for a specific topic? Head to our YouTube channel or website, prairiedoc.org, today to access all on-call with the Prairie Doc episodes. And make sure to join us most Thursdays on SDPB and Facebook for new shows.
My son is one of the many Americans with cleft lip and palate. The specifics of each affected individual's situation vary, but one thing they have in common is that they will be having surgery. Lots of surgery. Although most individuals with orofacial clefts, including my son, are otherwise healthy and lead normal lives, the process of restoring a normal smile, normal speech, normal chewing involves many steps from birth into adulthood. Most of his surgeries have blurred together in my mind. However, his first bone graft remains starkly vivid. In this surgery, bone is removed from the hip for implantation in the ridge under the nose where your front teeth are anchored. The pain where the bone was removed was excruciating. He was hospitalized for 4 days, and once home we struggled to keep him comfortable despite acetaminophen, ibuprofen, and 2 different opioids. We were understandably dismayed 10 years later to learn he would have to undergo this procedure again. Not enough bone had grown from the earlier graft to support the next stage of the repair. It was with great trepidation that we checked into the hospital for surgery earlier this summer. Despite the reassurances of our surgeon, we both expected the same gauntlet we had faced last time. We were wrong. In the intervening years, a new delivery system for an injectable anesthetic had been developed and then approved for use in young people. His surgeon used this medication at the graft harvest site, and the difference was almost inconceivable. He needed minimal supplemental pain medication during our single night in the hospital, and once discharged took only the occasional dose of Tylenol or Motrin. I suspect those doses were prompted mostly by the fear that it might start to hurt and not by pain itself. Like all of medicine, surgery has experienced change at an ever-accelerating pace, but the apparent revolutions are built on a foundation of step-by-step science. In medical school, I watched the first laparoscopic nephrectomy performed at the University of Iowa, a major tertiary care center. This amazing new technology could trace its history back nearly 200 years to a German doctor who invented a primitive precursor. Advancements in both medicine and technology have brought us to today, when endoscopic, laparoscopic, and robotic surgeries have become commonplace. The path to developing new techniques and technologies may not be smooth, but we are the beneficiaries of pioneers and scientists who move medicine forward. I am grateful for them all, as a doctor and as a parent. Thank you to our guests, Dr. Fromm and Dr. White, for volunteering their time to help us learn more about advances in surgery. If you would like to see and hear more episodes of this program, please like and follow us on Facebook and YouTube. So that's an exception to the be careful what you learn from Facebook. Or visit us at prairiedoc.org. Look for Prairie Doc perspectives in your local newspaper or online. And be sure to look for the podcast of this program, Prairie Doc on Call, wherever you get your podcasts. So, from all of us here at On Call with the Prairie Doc, thank you for joining us for another episode of health information based on science and built on trust. Until next time, stay healthy out there, people.
Neuropathy, like many chronic pain conditions, has a variety of causes and a variety of often less than satisfactory treatments. neuropathic pain, next time on Call with the Prairie Doc.
Mom, can you believe we are already entering the 21st season of On Call with the Prairie Doc?
It's amazing. Last year was so fun celebrating our 20th season. It was great to see the old shows and to just highlight the honest science and trust that our program is built on and that Dad started so long ago.
Yeah, and to see how it's grown. You know, to see it's not just a television program that you can find on Thursday nights at 7 o'clock, but it's something that you can check out on one of your favorite podcast networks or YouTube. Share these videos to your friends and family on Facebook.
There's a lot of ways that Prairie Doc is making an impact. We know it wouldn't be possible if it wasn't for you, our viewers, and for our corporate sponsors and our private sponsors. We are completely privately funded foundation, so your contributions make a difference. And did you know that a couple of years ago, the South Dakota Department of Health asked us to do some special programming that they felt was important for the whole state to know. We felt really honored that they would ask us to be a part of that. So you donors, you helped in providing good education for the state.
You know, as a nurse, one of my primary responsibilities is to advocate for my patients. And this program really allows our prairie docs, as well as the volunteer doctors, to advocate for public health across our state and into the surrounding states as well, which makes it particularly nice when a patient will come up to me and tell me that they really enjoy the program, or my parents watch your show every week.
Yeah, I hear that a lot, and it really is humbling and gratifying.
Yeah, and I'm excited and humbled to be joining the Healing Words Foundation board as we work to make an impact on the lives of our supporters and to further that mission.
If you would like to help us with this important work, we hope that you'll talk to your friends, you'll share our program on your social media page.
And if you want to make a financial gift, please give directly at prairiedoc.org or mail your gift to the P.O. Box 752, Brookings, South Dakota 57006.
Thank you for your support.
All right, Mom. You ready to go for a little walk?
You bet.
Let's get those steps.
Major funding for On Call with the Prairie Doc has been provided by
Avera is a proud sponsor of On Call with the Prairie Doc on South Dakota Public Broadcasting. Larson Manufacturing is proud to support On Call with the Prairie Doc as it continues to open doors for important medical information.
and with the ongoing support of these individuals and institutions, Brookings Health System, Ophthalmology Limited, South Dakota Academy of Family Physicians, Avera Heart Hospital, First Bank and Trust, Dakota Allergy and Asthma, Vance Thompson Vision, Monument Health, Black Hills Medical Society, Brookings Madison Flandreau District Medical Society, Pierre District Medical Society, Yankton District Medical Society, Orthopedic Institute, Lake Poncet Sailing Academy, Aberdeen Asthma and Allergy, Dakota Bank, South Dakota American College of Physicians, and Swiftdale Community.